Hello and welcome to another episode of the Atrium, CTSNet's podcast that's aimed at trainees. We have a really special episode for you today. We've got the wonderful Dr. Valerie Ruche here joining us. First of all, welcome Dr. Ruche, and thank you so much for coming on the podcast. It's a pleasure.
Well, thank you. It's my pleasure.
So we're really honoured to have you on our podcast, especially that we're aiming this at trainees because your career has been so inspirational. I actually know that Dr. Joel Dunning is quite jealous that you've come on to my podcast before you go on to the beat with him at some point, maybe in the future. So it's going to be a really great talk. So I just want to say, like I said, you are an inspiration to so many across the globe. And I just want to say thank you because it's so nice to see someone, especially a woman, pursue their careers and pursue their dreams and make so many changes and achieve so much. So I thought I would give a bit of an overview of your career before we get into the nitty-gritty, just so our listeners sort of understand your journey. So you're currently a general thoracic surgeon at Memorial Sloan Kettering Cancer Center. You did your medical school training at Columbia. You then did your surgical training at Washington before a fellowship at MD Anderson Cancer Center, and then you returned to the University of Washington as a thoracic attending. You then became Memorial Sloan Kettering Cancer Center Chief of Thoracic Surgery. And is it right that you were the first female chief of surgery there?
Yes, I'm the first woman to be what we call a service chief, which is really a division chief at MSK.
Great. And you've had numerous roles in various boards and societies across the years, as well as performing your clinical roles. So, chair of the American Board of Thoracic Surgeon, on the Council of the American Association of Thoracic Surgery, and you were in fact the 100th president of the American College of Surgeons, and only its fourth female. You've had multiple awards given to you. You've got over 450 peer-reviewed publications, 50 visiting professorships, and over 400 invited lectures. I think this is just such an inspirational career. And I don't think sometimes in surgery or as women or actually just in general in the world, we give ourselves that pat on the back. So I really want to start by asking you, what are you most proud of in your career that you've done? Whether that's clinical or non-clinical, that you're going to look back on and think, I'm proud of that moment?
Well, I wouldn't say that it's one thing. I have closed my clinical practice at this point in my career, but I really enjoyed taking care of patients a lot.
Yeah.
I also enjoyed surgical education a lot. And I think I'm proud to have trained many residents and fellows over decades and have contributed to their careers. And then I'm proud of the multidisciplinary work that I've done in a number of spheres. Multidisciplinary because sometimes it's multi-specialty within the world of surgery. But because I work mostly in the world of oncology, it's a multidisciplinary in that, from that point of view.
Yeah. It's really nice for you, like, even though I've obviously said sort of like one thing, it's really nice that the whole aspect of your career you're proud of, because I think that's something that we all should be aspiring to be, that multifaceted approach. There's so many aspects, and I know you've talked in the past about, we don't always aspire to be, a president of something or a chief on the board of something. But, it's really nice. I think you've inspired so many through those roles. It comes with some negatives through your career. What would you say are some of the hurdles you've had to face through your career?
Well, certainly still today, but most of my career, I've been either the first woman or the only woman or one of very few women. And that's less true today in the United States. but it's very true in other countries around the world. If you work in particularly lower and middle income countries, by and large, there are very, very few women surgeons in general, and even fewer cardiothoracic surgeons.
Mm. And were there any particular moments, like in your career, where you sort of hurdle to get over, or moments you sort of doubted yourself? Because I know that that happens to a lot of us.
Yeah, I think that you have to have the persistence and the patience and the resilience to do what really interests you.
Mm.
I've never looked at my career from the standpoint of, oh, I need to become an officer or a president or a committee leader or whatever. I've really done, pursued what interested me from the intellectual standpoint
Mm.
and been open to opportunities as they arise. I've taken a few left turns or right turns in my career because new opportunities opened up or because the field was changing or technology was changing. So I think you have to have that flexibility to
Mm.
go where some of the opportunities are. My sister always says, when one door closes, another opens, because sometimes you think you've really not managed to achieve what you wanted, but there's almost always another venue, another path that you can pursue that leads you forward.
That's
So
nice to hear.
yeah, yeah, you just and I think importantly, if you don't focus on what you're truly interested in from the intellectual standpoint,
Mm.
you're going to be endlessly frustrated.
Mm.
If you're doing what you really enjoy, what gets you out of bed in the morning to go to work,
Mm.
then you can move past whatever political or financial or personal hurdles may come in your path.
Yeah, I think that's something that, as trainees, we should always remember, because it's difficult. Yeah, whether in the UK it's difficult, I know in the US it's difficult. Work hours, like you said, politics, and just always having that sort of check in with yourself about why you're doing this career. And I know you've talked in the past about the fact that your career sort of serendipity has had a huge part to play in it, and that's how you end up in oncology. Is that correct? Yeah.
Yeah, I never really thought that I would go into cardiothoracic surgery, but I learned that I enjoyed doing it when I
Hmm.
was a resident in general surgery. And fortunately, in the era in which I trained, we did a lot of cardiothoracic surgery in the course of general surgery residency.
Mm.
So I took kind of a left turn there, but because someone who is division chief said to me, "Why don't you consider this?" And I did. And then I actually originally planned to do cardiac surgery. And as I started through my general thoracic rotation, which is, we train in both in the
Yeah.
US, I realized that I really liked general thoracic surgery because it was very intellectually stimulating. And you also had a lot of input and governance over the care of a patient longitudinally, which was less the case in cardiac surgery.
Mm.
So I took another left turn. So,
It's nice to know, because sometimes we sort of, it feels that we should always have our decisions set right from the beginning, and we should know what we want to do, and that's the true dedicated surgeon. Whereas actually finding your path is just as important, it seems.
yeah. And when I came back, my year at MD Anderson was actually an interim year,
Hmm.
sort of at the level of an instructor. So I wasn't
Hmm.
really a fellow or resident. I
Mm.
was an attending, but at a junior level. And my original plan had been to come back to the University of Washington, where I already had a job offer to be a faculty member and work at the VA hospital because I thought I could do both cardiac and thoracic there
Hmm.
and also have some protected time for research and access to the VA funding stream to support research. And for a whole variety of reasons, it turned out that that wasn't going to work. And
Hmm.
I had to make a choice between cardiac and general thoracic. And in the net result, I decided that general thoracic was probably a little bit more interesting.
Hmm.
Never really planning a career in that was oncology focused. But there you have it.
Yeah. And obviously, the career you've ended up having, it must be so different to what you imagined it would be due to the changes in technology and treatments of which, you've been at the forefront, neoadjuvant chemotherapy and targets. How's it been to be at the forefront of those changes?
Well, I often joke that the world is divided up into two camps, the individuals who embrace change and the individuals who resist change. And I think that if you're a surgeon, and particularly a cardiothoracic surgeon, hopefully you fall into the camp of individuals who embrace change, because one of the great things about a career in CT surgery is that it's changing all the time. And that it's a very rapidly changing area, and it's changing a lot because of technology, of techniques, of biology and our understanding of biology, be it cardiovascular disease or oncology or transplant, whatever your focus is. I think it's very important to embrace lifelong learning and have the flexibility to learn new things, learn new techniques, new technologies to shift your thinking. It's really one of the great aspects of our specialty, but not everyone is comfortable doing that.
It's actually one of the things that has sort of appealed to me about cardiothoracics, because I'm someone who loves learning and I just know this specialty is going to give me that. But it's not always, even though we've made so much progress, like we said, especially in terms of women and especially in terms of the changes we've seen, we're so different to how we were many years ago, especially when you started training. And it is people like yourselves that have proven to trainees like myself, you've just got to keep going and overcome those barriers. And I think that's something you learned from your mother, was it? Just that, just work hard, excel at whatever you're doing, and just go through those barriers.
Yeah, well, both of my parents. My mother was a feminist before the term really was in common use. My father really always said, no one can argue with excellence. And that's not always the solution to everything in life, but it's a good thing to remember.
Yeah, I really like that because it proves to you just work hard. Well, not just work hard, but work hard and, it'll pay off. There's obviously still some barriers in our specialty, both clinically and sort of on a more of a training level. What do you think that the barriers that our specialty needs to tackle in the coming years needs to be? Maybe, in both aspects of it.
Well, I think the statistics speak for themselves, right? If you look at the percentage of women in cardiothoracic surgery in virtually any country around the globe, it's abysmal.
Mm. Yeah.
It's usually, and up until just the past few years, even in the US, the percentage of women in cardiothoracic surgery was still in the single digits. Well, it still is for adult cardiac and pediatric congenital cardiac. And we're now somewhere in the range of 15% in general thoracic. And everyone's cheering about that. But, we're really lagging behind a lot of other specialties. I think in the US, maybe orthopedics and neurosurgery are faring worse than CT, but not by much. We have a lot to do to make this an appealing specialty to women. I think we need to get the message out there that it's a perfectly normal choice for women, that we need to get past salary inequities, which are very common, again, in most countries around the globe. It's unacceptable, and I've certainly been on the receiving end of this in the course of my career. It's unacceptable for individuals who are female to be having a lower salary than their male counterparts at the same level for more or less the same responsibilities. That's got to go. And we have to have appropriate provisions for parental leave, maternity
Mm-hmm.
leave,
Mm-hmm.
so that it becomes possible to combine families and career, which certainly was not the case in the era that I was training.
Yeah.
And the world of medicine will be better off for it. And then we have to make opportunities available. I think one of the good things that happened at the 2024 AATS meeting,
Mm-hmm.
and this was really the insistence of Lars Svensson, that there be for every single session that was being held, that there be a male and a female moderator, and that we pay attention to gender distribution in terms of commentators, discussants for papers. I literally, with my co-chair for thoracic, we had the ATS provide the list of female members, and where there wasn't someone who was quite right for that particular session, we reached out and we found someone. And even though the ATS still has a much smaller percentage of women than men members, it was possible. I just came back from a meeting in Europe. It's not a reflection on Europe versus the US, but happened to be in Europe. And it was noticeably different. And there were very few women at the podium as moderators, as commentators. That kind of message really goes through to the younger surgeons who are in the room. And I had someone come up to me during the ATS and say, I can't believe it. This is great. This is a young woman surgeon. I've never seen it like this. So that kind of a message speaks volumes.
Mm.
So those are some of the things I think we need to do.
Yeah, it's really, nice to hear, because obviously you've gone through your career and you've achieved so much, but it's so nice to hear you still trying to, push. You're accepting that you've done it, but that's not the same for everyone else, and we still need to change the specialty. At the meeting in Europe, I saw a great speech from yourself at EX. It was great, and I like the fact they had these speeches, these different talks with women and tackling the barriers, and there was lots of men in the audience. If you could have your career again, or your training again, part of your career, would you do anything differently?
Oh, absolutely. I think really in the era in which I trained, which is a million years ago, 1970s and 80s, there really was much less mentoring than is available today to both men and women. I certainly had no mentoring to speak of. I found some mentors as I went through my early career, but formal mentoring, which is now in place in many training programs, certainly here in the US, it's a formal part of training. And if I had to do it over again, I most certainly would have taken out 2 years to do research during my general surgery residency, which in that era was sometimes available in training programs, but many times not. And now it's more commonplace. And I would have gone down the path of becoming a physician scientist. You can't do that over again, but that's what I would change if I had to do it again.
And obviously there would have been moments where, like you said, you didn't have mentors. What did you do in those situations, if you just needed that guidance, advice, and how did you persist? Because like we're saying, we still don't have enough of this mentor, we're better, but we're not completely equal, and many females may feel that there's no one around them that they can, admire or reflect on. What do you do in those situations?
Take the initiative to reach out. The couple of people that were very helpful to me early on were men, because there were no women around to talk to. But they were supportive and listened and made opportunities available. And so I think mentors may be female, but they may not be. They may be within your specialty, but maybe not. And often, if you're an academic surgeon, you want to perhaps have someone who's a clinical mentor, but also someone who's an academic mentor, and they're not always one and the same person. They're often different individuals.
So find the mentor and don't, limit yourself to just looking for that female thoracic surgeon.
Right, exactly.
Find that person.
Yeah. The person who helped me the most when I came back to the University of Washington was not someone in the Department of Surgery. It was the chief of medical oncology.
Yeah. So just being sort of opportunistic about who you see. And touching on that sort of topic of serendipity and opportunistic and things like that, do you know when those sort of serendipitous moments occur? Did you sort of know at the time, did you think, oh, this is something I should do, something I should change? Or was it more sort of the path just found you?
Well, both. I think there are moments that come up and where you intentionally can identify them as being an opportunity, and others that sort of arrive at your doorstep and you say, oh, gee whiz, I could do that. That's might be really interesting. Having said that, I don't think it's a good idea to just sort of wander through your career either. And
Hmm.
I've tried to periodically take a step aside or step back and reflect on where I am and where I'm going.
Hmm.
And I think certainly if you do that more or less on 5-year increments, that's helpful. Sometimes at various points in your career, you'll realize you've been asked to serve on a gazillion committees, and half of those are just not where you should be investing your time and effort, and someone else would be more appropriate for those positions. Or you're just not able to live up to some of the responsibilities that you've been given, or you need to take time out and learn something new, whatever it is. But I think taking a moment to reflect on where you are and where it might be good to head for the next 5 years is always a worthwhile exercise.
You have to balance so much, and obviously you've done, your clinical, your academic, your education side of things. How do you do that? And have you ever had to sort of learn to say no to things?
Yes, correct. So, probably the biggest challenge for everyone in academic surgery is time management. Emeritus chair of surgery where I work, who's famous guy, Murray Brennan, the author of literally 1,000 peer-reviewed manuscripts, I might add, world-renowned surgical oncologist. The fellows would come to him, or he would meet with the fellows every year to talk about career planning. And they'd always come to him with, questions about program location and salary and lab space and this and that. He would say the single most important thing you need to negotiate is time. And I think that actually holds true unless you're going to be only a full-time clinician,
Hmm.
then your time commitment is clear more or less for that. It doesn't matter whether you're going to do laboratory-based research or clinical research or whatever. You have to have what I call thinking time.
Mm.
And some of the resources available to you to make that thinking time a reality. So some of the resources could be space, they could be personnel, people who offload you in terms of clinical responsibilities, whatever. But I think that time is probably the most important commodity for any of us.
Great. And obviously, we've talked about lots of different things today, and it's been just great to hear about all these different aspects and ways that, things that you've done and things that you'd do differently. Sort of, what would be your overall advice to trainees? New trainees right at the beginning of their career, right at the beginning.
I think when you're in the very beginning of your residency training,
Mm.
or what you call registrar,
Mm.
um, sometimes it's hard to know exactly where you're headed. Now, a few people know from age 5 that they're going
Yeah,
to be a cardiac surgeon, right?
yeah, not
but
me.
but most of us arrive at that decision after going through a lot of different life experiences. As you gain some level of experience, it's important to try to identify what really interests you so you can then identify a focus. And that becomes more and more important, I think, as you get through to the latter part of your training. And what I used to counsel my young, fellows going to faculty said, think about what it is that really energizes you. What do you want to be investigating? And whatever you're really interested in academically is also going to fuel your clinical practice. So
Mm.
think about that, because what you want to do is coronary surgery. There's no point in uh, focusing all of your academic interests on aortic surgery, just as an
Hmm.
example.
Yeah.
There's no point in writing about lung transplantation if what you want to do is thoracic oncology, et cetera. Identify a niche
Mm.
and become become the world's expert in that niche, because that's what will take you ultimately, if you are the world's expert in a certain area, can take you very far academically as well as clinically. And then all of the issues that we've talked about in terms of trying to find the right environment and having enough time, et cetera.
Great. It's been wonderful talking to you. Thank you so much for helping these trainees. I think, what I've really taken from it is that key thing of find your niche, find your passion and what gets you out of bed. Make the time for it and time manage yourself well. And then try and find a mentor. And that doesn't have to be someone directly in your field, but, just someone to help you along the way. And always strive for that excellence, because that will help you. Thank you so much, Dr. Valerie Riche.
Oh, it's a pleasure. Thank you.
And I'm sure our listeners will love this. Thank you everyone for tuning in, and tune in again next month for another episode.